Well, a warm welcome to this talk. It's Monday the 25th of March and we've had a great day today. We've been invited to the home of Professor Robert Clancy in Australia. Robert, thank you for the invitation and your brilliant hospitality and for showing us around.
Great pleasure.
We have another reason for doing this video today, don't we? What have we got in mind?
Well, John, the main reason was to give you and Chris a little break, given the intensity of recent years.
Thank you.
But being here, the professionals in health and legal and pharmaceutics, etc., got together and said, why don't we use this as an opportunity to bring together the best of the best that we can find in Australia that are concerned that we may not be getting as much out of reviews of the COVID problem as we should. And so in a sense, we're looking at doing the Royal Commission that the government probably didn't want to do. And so on Tuesday, the 2nd of April, we're having a day, a symposium, where we have a terrific array of individuals, including yourself, John, where we're looking at different aspects, the way we've seen the COVID pandemic, how it's been handled, the good, the bad, and probably the indifferent, and particularly looking at ways we can go ahead. Because we started COVID with a plan, and the plan didn't sort of go to plan, it disappeared, and a narrative took over. And the question really is, was the narrative as good as the plan that we had in place?
And this is going to be the Australian Medical Professionals Society.
Exactly. It's sponsored by a number of groups, but primarily through the Australian Medical Professional Society, which itself is a group that's come together with professionals across the spectrum of health, nurses, doctors, pharmacists, various epidemiologists, individuals who felt that maybe we haven't done things as well as we should, and it's become a very strong organisation, and they're sponsoring the meeting on Tuesday.
So there'll be a variety of professionals with high qualifications, high levels of expertise giving input into this conference.
Absolutely. We have family practitioners who have been right at the forefront of this pandemic. We have various specialists like myself. We have epidemiologists, pharmacologists. We have legal individuals, professors of medicine, a whole variety of people who are looking at through different prisms. And we're also having a session which is at the end of the day for a couple of hours, a workshop which will involve the audience and which will involve everyone, where we're trying to identify specific ideas, specific ways in which we can go forward, so we perhaps can do things a lot better next time.
Let's hope so. So to me, a lot of the problems that have come to mind in the past 3 years maybe, become obvious to me in the past 3 years, when we look back, perhaps I've been a little bit naive before the pandemic. There were problems developing perhaps for the past 10, 20 years really, that the pandemic has sort of crystallized. I mean, what are the sort of standout issues and problems for you? What sort of things will we be talking about in your presentation, for example?
Well, what I'm talking about is a plan that was put together over 120 years. Australia has a very proud history in both the running of medicine and in the science of medicine. And as a result of experience through half a dozen pandemics, beginning with the Black Death in 1900, through the flu pandemics from 1918 to 2010-11, we've developed a very strong public health service. We've developed a particularly strong medical research a range of institutions led by Macfarlane Burnet in the first instance, and as a result of that we developed a national plan for handling a pandemic involving an inhaled respiratory virus. Well, we thought it would be flu, but as you know, coronavirus is starting to rear its head 10, 20 years ago, and the one pandemic we got was a coronavirus pandemic, but the principles were the same. And so up to in 2019, we had a refreshed plan. We practiced for the plan. I was talking to a general practitioner recently, and she was saying, oh, I can remember we'd go out to a local oval and we'd practice all the ways in which we would cope and handle that plan. And the plan was based around several principles. The first was the epidemiology. What is the pattern of the disease? Learn about it quickly, identify what we need to do. And nowhere in the plan was things like shutdowns. Nowhere. The second principle was vaccines. Vaccines never centred as the central component because they just don't work that way. Vaccines against inhaled viruses are never going to be as effective as, say, a measles vaccine or a mumps vaccine. It's just the principles of the biology. And the third area was respect of the doctor-patient relationship, where decisions about how you manage your patient is made within that relationship. And I'm looking, particularly in my presentation, at how those three planks were enacted, where they went wrong, and how hopefully we never make those mistakes again.
So it's really quite bemusing. This detailed plan had evolved, been developed over 100 years. Yeah. And then when the actual crisis arose, it was just we were ignored. We
were handed a narrative from North America and parts of and World Health Organization and various international, and say, hey, this is how you're going to do it. And it was so wrong.
Yeah.
So wrong in so many ways.
I mean, one example that really got to me is you're a lifelong physician. You're a consultant physician. You're a professor of medicine. You're a doctor of science, doctor of medicine, doctor of philosophy. You're as experienced as doctors come. And when you see if I come to you as a patient and you decide, well, John, I think you need a particular drug, then I want that drug. Because who else am I going to ask? And you could not prescribe the drugs that you thought were best for your patient.
I think that's what got my attention in the first instance. Yeah. I mean, it was a particular drug. I mean, hydroxychloroquine, a drug that, in a recent article I wrote, I worked out that I'd written 25,000 prescriptions for this drug without one serious side effect. And here, bureaucrats were telling me and my colleagues within the doctor-patient relationship that I can't discuss with my patients with a host of information saying, hey, this really works. I couldn't do it. In one state in this country, in Queensland, you could go to jail for prescribing an accepted drug, a drug that's available, that's used every day by thousands of people in this country. It just didn't make sense.
I mean, the arrogance of bureaucrats thinking they can tell you.
Yeah, it is. It's funny, isn't it?
How to prescribe medication. It's hilarious if it wasn't tragic.
I mean, if I was telling them how to do their job, they'd be the first to complain.
Yeah.
But they were telling, look, nothing special about me, but they were telling me how to do my job. When I've been teaching people how to do my job as a profession all my working life.
I mean, last time I was on a flight, I wasn't happy with the way the pilot was flying the plane. So I barged into the cockpit and said, look, Mr. Pilot, you're pressing the wrong button. I'm going to sort you out here. I mean, the arrogance of that is just beyond description.
And I think what's happened, I've tried to work this out, and I can't, but the medical profession has changed so much in the time I've been working as a consultant physician, as a clinical immunologist. It's changed. We used to have control mechanisms. We had people who were role models, senior individuals, senior doctors, and there was a trickle-down educational effect. Evidence-based medicine was always how we ran medicine. You know, I often laugh when some pharma company promoted idea is that, you've got to use evidence-based medicine. It's as though
we never thought of that.
Oh, dear me, what a good idea.
Thank you for that one.
Yeah, that was very helpful. And all of a sudden, for the first time in my professional life, I'm being told how to manage my patients the best I can with all the information I have and in agreement with the patient. Yeah, the whole principles of Dave Sackett, who we've talked about before. Dave Sackett, who I worked with for 5 years in Canada, who put together the ideas of evidence-based medicine. They're all lost. And they've been focused and concentrated in a very narrow zone that suits just a restricted group of individuals.
That's partly what I'm hoping to do in my presentation. The ideas of evidence-based practice, evidence-based medicine, we need to use the best available evidence. But that evidence ideally comes from trials. But if a particular vested interest is determining what trials can be carried out and what trials cannot be carried out.
And what outcomes can be found.
Absolutely. And the way you ask the question, of course, can influence the
John,
outcome.
that is such a simple statement, and yet, it's the first time I've heard anyone say it, and yet it's got to be true. We're hit with this randomised controlled trial, but if that's run by a pharma company putting in $100 million, it says, okay, this is the outcome we want. Oh, we don't want those patients in this trial. So you construct the trial to give you the result.
Yep.
Just as there was influence to construct trials on things like hydroxychloroquine. Well, let's only put people who are in hospital. Now, everyone watching this knows that if you have any virus, you have shingles, you have cold sores, you've got to treat that within 2 days. If they go to hospital, it's too late. And so we had this dichotomy of evidence-based medicine that I think is distorted. And these, I think, are some of the issues that we need to discuss on the 2nd of April.
So if you're going to give a drug which has a potential antiviral effect, shall we say, like hydroxychloroquine, perhaps with zinc as well, there's no point waiting until the patient is a week or 10 days down the line, because they've already got over the acute viral infection and they're suffering from inflammatory complications and post-viral complications.
Absolutely. You're so far down the train of events that you've lost that opportunity. So and everyone knows
if someone wanted to, they could construct a trial taking patients that were diagnosed 7 days, 10 days ago, giving them high doses, incredibly high doses of hydroxychloroquine.
Which can be toxic.
Which can be toxic. And then saying, oh, it doesn't work. But of course it doesn't work. It's got to be in a particular time frame.
And, why don't my colleagues pick this up? I talk to people I've known, highly intelligent, highly competent doctors. I sat next to a family practitioner at a meeting recently, and she asked me, and I answered, and I don't think she believed a word I said. And it was just a waste of time trying to continue the discussion. This is ABC medicine. It's not complex.
Yeah. And also in evidence-based medicine, of course, we need to take expert opinion, but that's largely channeled through the authorization bodies, isn't it? The FDA, the TGA,
Well, it's changed, you see. It used to be channeled through, for example, I'm an internist, I'm a physician, and the College of Physicians had a structure. The College of Physicians now has become essentially a tick. You get a tick, yes, you pass the exam, you can become a physician. Oh, we'll do a little bit of keeping you up to date, etc. But they don't provide that leadership role that we once. I mean, it used to be that the top people competed to become the head of the College of Physicians.
Sure.
I mean,
well, very prestigious.
I don't want to be rude, so I won't say anything, but it's changed.
Very prestigious title. And then, of course, evidence-based practice allows for patient preferences and what's tolerable to the patient. But how can the patient express preferences if that's based on publications which might be questionable, and if that's based on expert opinion which may be compromised? The patient can't make informed.
It's very difficult. And I think,
decisions.
And in fairness, it's extremely difficult for, say, a family practitioner who is going to get someone coming in with an ingrown toenail, and then someone coming in with COVID, and then someone coming with cancer of the bowel. I mean, all that can occur in 35 minutes. And it's easy for me to keep up with my little area of clinical immunology and COVID, etc.
Not that little, but
Well, relatively speaking. And I have huge respect for the frontline doctors, and they have been let down so badly by what's happened, I think, in COVID. Put in an awkward, difficult position. And they're the people who are saying enough's enough. We want to create AMPS, for example, as a new way of looking at where we're going in health.
And it really is a pleasure and a privilege to be part of that. It's great to be involved in that. Now, you mentioned before there's this particular narrative. Now, part of this particular narrative at the moment is massive investment into mRNA vaccines. Now, I use the term vaccine advisedly here because an mRNA vaccine, of course, is not giving an antigen. To me, a vaccination is giving an antigen. This gets the body to make its own antigen, which we know has its own problems. But this is huge. In the UK, the Moderna plant, 250 million doses a year. In Australia, 100 million doses a year. Canada, 100 million doses a year. Huge investment into this mRNA technology, not just for COVID, but for other things. Should we be concerned about this?
Well, it reminds me of, I think it was the 1700s, and we have the Pacific bubble. And in Holland, it was all about tulips that were worth $1,000 each. I don't understand how humanity can buy such extraordinary nonsense as this. Let's be crystal clear. There was not one indication for using messenger RNA vaccine, genetic vaccines for COVID. And it's been proven within a couple of months of the messenger RNA vaccines, with all the money that went into it becoming available, so did the old-fashioned vaccines. There's not a jot of evidence that the messenger RNA vaccines can be any better in terms of efficiency, but they're sure a lot worse in terms of toxicity. Yeah. There's no question about this.
No question at all.
And it's very interesting. Recently in Hong Kong, they compared the China, I think it was a couple of the Chinese whole virus vaccines, old-fashioned type vaccines.
As we've used for hundreds of years.
Which we've used for 80 years anyway. It seems like 100, doesn't it?
Well, I mean, it goes all the way back to cowpox and smallpox in a sense, doesn't
of course. It does. Back 1799 or so. So we suddenly, they compared how the genetic vaccines did with the non-genetic, the traditional ones. And there's no difference in efficacy, but a big difference in the safety issues. And that's worries the hell out of me. And the important point is they were never, ever going to be particularly good. And anyone watching this can say, where have you seen you need 4 or 5 vaccines in 2 years to protect you? And if anyone is honest with you, they'd tell you, oh, the biology says it's not going to work. In fact, it's going to turn off your immunity. You're going to get more infections, more severe infections, and you're having your boosters simply to keep up a touch of transient protection. It's that simple. And they're so far behind the virus that's around today that it's close to ridiculous.
And all the time we've got this risk-benefit analysis. You get this tiny increase of antibodies for a very small period of time, but you're stimulating other immunosuppressing mechanisms.
Exactly. And that's the difference between a virus that infects the airways, like flu or COVID, and a virus that goes through the bloodstream, like measles and mumps, where you get highly effective protection. I mean, there's no doubt that the COVID vaccine offers some protection against severe infection when it escapes from the airways. But there's so many other ways, simple ways you can treat those patients.
No, absolutely. And one of the other things I want to talk about is the low-hanging fruit that we're missing. You know, there's so many simple treatments, perhaps repurposed drugs, new drugs that aren't necessarily under patent for $15,000 or $30,000 a course.
I know.
And it just seems strange that all the new drugs that have come out lately, are quite expensive, and drugs that are cheaper have been
You think governments would be interested in this just from
just to save money
viewpoint? To save money. I mean, the drug that I think is most used in my country, in Australia, is a drug called molnupiravir. Now, I'm sure you're aware of the Oxford study. 20,000 people. Now, they were trying, as far as I can see, to make this drug work. They gave it every opportunity. There was no protection against admission to hospital, which is a marker of more severe disease, in a study involving 20,000 people. And yet that is the drug which is prescribed to most people in this country with COVID for about $1,000 of taxpayers' money per course. I ask you, where is the sense in that? And you've got ivermectin, hydroxychloroquine, drugs that I use all the time, which cost, what, $1, $5, $10? Highly more efficient. More efficient. The data's all there.
And the viewers may have their own views. We couldn't possibly comment.
Maybe I'm wrong. Yeah.
They may have their own views on why the most expensive drugs are chosen and cheaper repurposed drugs are completely ignored.
I mean, it's beyond my capacity to understand that.
But we've got a lot of smart viewers. They might have a few ideas on this. Yeah. So this video is just a very quick promo. There's many things we could talk about, but we're looking forward to this conference, and we're hoping to be able to report on it in some detail. We're hoping it's going to be a video. Very high caliber people, lots of things to say, so much to learn from the future. Let's not make the mistakes of the past, and let's go forward into a healthcare which is of the people, for the people, by the people. Is that
John,
to hope for?
I think, just on behalf of so many people in this country who have been comforted, supported and helped by the objectivity you've brought to a very confronting and complex pandemic, they're so grateful. Unfortunately, there aren't too many seats left.
No.
But there may be a couple, and if people look up the AMP's website and say that they were invited by us on the thing, we might be able to squeeze a few extra seats. But so it's next Tuesday. They have to hurry. And
it is in Sydney, which is a bit of a problem for some people.
At the wonderful State Library with the brand new, it's a wonderful venue.
Well, thank you for those kind words, Robert. And we do hope to have some of the details so that we can share the very high levels of expertise that are being brought to this problem. People around the world are realizing there is a problem. People with high levels of expertise are starting to address it, and personally that gives me hope for the future. But for now, Robert, thank you so much, and thank you for watching this video.